Welcome to this Health and Wellbeing Board meeting, Thursday, 8th February, County Hall. And just a few caution that we are on camera and we are being videotaped and audio taped, so if you're exposing your laptop, it might be exposed to wider public. Okay, just to be aware of that one. So, as usual, we start by introducing ourselves, just a word, and when you do so, you press the mic, speak, and switch it off. So that will also be a training before you ask any question. So I am Councillor Paul Egil-Shelvan, Councillor for Cramlington South East, and I also chair this board.
I'm Dr. Graham Sayers. I'm a GP in Alnwick. I am a clinical lead at the ICB in Northumberland.
Hello, I'm Veronica Jones. I'm a County Councillor for Ponteland West and the Cabinet Member for Public Health and Inequalities.
Morning everyone, I'm Director of Public Health for Northumberland County Council, and apologies Chair, we'll probably have to leave at about 11 o'clock.
Liz Simpson, County Councillor Newbiggin.
Good morning, I'm Brian Moulder. I work for Newcastle Hospitals and I'm representing Victoria McFarlane-Reid, who's unable to make it today.
Good morning, Peter Stanfield, Chair of Health Watch Northumberland.
Hi, Jeff Watson. I'm a County Councillor for Amble West with Warkworth and also the Cabinet Member for Health, Healthy Lives.
Al O'Neill Bradley, I'm the Executive Director for Adults at the Council.
Good morning, I'm Graham Writer, Director for Children's Social Care, Young People and Families at the Council.
Morning, I'm John Lawler, Consultant in Public Health at Northumberland County Council.
Hi, I'm Emma Anderson, Deputy Director of Nursing for Children, Young People and Safeguarding for HDFT.
Good morning everybody, I'm Steve Kennedy, Assistant Chief Fire Officer, Northumberland Fire and Rescue Service, and I'm here on behalf of Graham Bennon, who can't make it. Thank you.
Hello, I'm Abby Conway, Chief Exec of Citizens Advice Northumberland, representing Thriving Together, which is the Local Authority Commission support service for the voluntary sector.
Morning, I'm Alistair Blair, Exec Medical Director for Northumbria Healthcare.
Good morning, my name's Sherry McCartney. I'm the Group Nurse Director for CNTW Mental Health Trust.
Hi everyone, Lynn Patterson, Deputy Director for Northumberland Place as part of the ICB.
Good morning everyone, my name's Dan Jackson, I'm the Director of Policy and Involvement in the ICB.
Good morning, I'm Janelle Clough and I am the Northumberland Community Anchor within the Growing Healthy 0-19 service.
Hello, I'm Rachel Rispin. I'm one of the service managers within Northumberland 0-19 Growing Healthy service.
And I'm Leslie Bennett, Democratic Services.
Thank you all. Okay, so first item, apologies for absence. I think Glenn will be joining late. I don't know how.
Apologies from Graham Binning, Victoria McFarlane-Reid, and Hilary Snowden.
Okay. Now then, second, minutes of the meeting. Can I pass them as a true record of what happened on 11th January 2024? I wasn't here, so yeah. Thank you very much. Disclosures of interest. Any disclosure that we should know of? I believe it's none. Thank you. That leads us to the fourth item, the one and only major item for this meeting, I think, which is the Growing Healthy 0-9 Service Annual Review. You're going to present that. Thank you very much. Yeah, so there will be lots of questions. Questions are encouraged because this is the only item we have. So if you want to say short period of time, don't ask any questions. But if you want to say longer, keep asking questions. Thank you.
Okay, thank you.
Sorry? Oh, I'm sorry. Yes.
That's
yes,
okay.
Yes.
Fine. So all I want to say is, sort of 3 years ago, we had a partnership with Northumbria Health Trust to deliver our services in Northumberland was dissolved. Most of our services, like social care, were taken in-house by the council, but there were some, such as our 0 to 19, which include our health visitors and school nurses, needed to have a health service provider rather than a council. So was it October 21, through a Section 75 partnership, we partnered with the Harrogate District Foundation Trust, who were already delivering services in the North East. The purpose of this report, as I understand it, is to update us on the 0 to 19 growing health service and advise on progress to date, and to give us assurance that the teams are delivering that high quality service to our children and young people. I think we've worked really closely in the partnership, and the progress on the recommendations shows that, and shows what a sort of how well and how mature our partnership now is after those, is it 3 years now? So I think you've just been introduced, Rachel, our service manager. I also want to say I think the service user and family feedback is really reassuring. So thank you. But I'll let you carry on now. Thank you.
Okay, thank you.
Thank you, Veronica. Thank you.
Thank you. Okay, I think you'll obviously all are aware of the annual report, so we're just going to draw out some key themes and look at some of the innovation that we've been doing and new roles. So next slide, please. Just want to start with, excuse me, looking at our performance, and this performance relates to our mandated contacts. And as you can see, for those, our performance is either largely static or generally improving in its trend. All our staff have a quality and performance one-to-one supervision monthly and a records audit, and that's really around ensuring that quality of delivery. Our performance leads within the service and management team work really closely with our locality managers, working with the staff on the ground to put in further support in place to enable those mandated contacts to be carried out in timescale where there are issues and any dips in performance and trends. We are in the process, although now we look locally at where performance trends are sitting, we are now developing performance panels in our local areas to move more formally to understand specific issues within the localities that do impact on our capacity and the ability to consistently deliver that high quality service that we want. Our performance leads are currently rolling out presentation and work staff for all our staff on the ground so that they can help understand performance, KPIs, etc. to support that delivery of care and the equitable service. Contributing to that quality and performance is the Harrogate and District Foundation Trust model of learning and best practice. So all our managers have a thematic lead within the service and are part of a work stream. Those work streams include patient experience, SEND, Best Start in Life, education, workforce and training, early intervention and prevention. In those work streams, that's where a lot of rich work goes on, looking at evidence, using experience, best practice, and looking at processes and work plans. Though the sort of work that goes on in there feeds into the Learning and Best Practice Forum, which is led by senior managers, and that's where we look at rollout of processes and policies, have quality assurance around the work going on. Okay. In terms of performance, it's probably right to lead now on to workforce and our recruitment. There does continue to be significant challenge in line with the national picture around recruiting specialist community public health nurses, SCIFINs as we call them, and that's health visitors and public health school nurses. Our vacancy factor, though, within Northumberland is starting to decrease. Recruitment of SCIFINs is really high profile within our organisation, and that recruitment and training staff. In September 22, we saw 8 of our public health staff nurses from in the service go off to undertake the 1-year SCIFIN degree programme. Now all 8 of those are in post within Northumberland, commencing their posts in September 23. So, and in September 23, we now have 6 more Skifton students in training within Northumberland. We're already planning for next year and plan to have the same model of training. We now directly recruit into Band 5 staff nurse positions within the organisation. They then hopefully go on and usually want to, as a development opportunity, train as Skiffins. So that real grow your own model is working well for us, and obviously recruiting locally people that live in the area, the travel isn't an issue, really does aid our retention. I think there is, we're addressing challenges by looking at skill mix opportunities within the teams, looking at different roles, which we'll come on to talk about to support the service. When posts become vacant, we're continually evaluating those posts and seeing how we can be innovative and creative in our recruitment. I think it is fair to say that there are areas of Northumberland in line, with, I think, other services, particularly in rurality, where it is more challenging to recruit. The north of Northumberland be an example of that. It usually largely is around relocation, so that's something we work hard with. We work with our HR recruitment team within HDFT, again looking at innovative ways of recruitment and pursuing that. Okay, I think next slide. We're just now going to, obviously, as you've said, for the last 2 years, we've been transforming our service, and that's come with that some new roles. So we're just going to touch on those. One of the new roles that's having real impact for us is the community anchor role. Janelle is sitting here, so she's just going to talk through this slide and some of the key transformations she's been working on.
Thank you. So my role is, it became active in January 23, and the brief was around exploring asset-based community development and addressing health inequalities, and how can we no longer work in silo as NHS practice. How can we get there into the communities to understand exactly what the need is, what the assets are, and how can we as a service collaborate with our partners to build upon those assets in the community. So over the past year, it's involved a lot of networking, going out in the community, a lot of active listening, a lot of finding out what is the experience of living in that area and what do our families want. It then leads to feeding back into service development and also feeding back into the 0 to 19 team, letting our staff know what is out there for our families so that we're getting a quick support there for families to maximise their health and well-being. So I have professional forums where I invite partners to come and give our workforce some up-to-date information around their offers. And I also have an in-house resource diary that I keep refreshing to make sure that they've got information that they need when they need it to support families and young people. I've been very actively involved in the Family Hub development and sitting within the work streams there so that we've got that voice and that understanding around what young people and children and our families need. Working forward, we've been working very closely with Northumberland County Council, and I was part of the Cramlington Conversation. And again, that's about that active listening. What is the experiences of our families, and how can we bridge that gap to make sure that we're developing a service that is required and wanted by them. One of the big projects that I'm working on in collaboration with a range of partners is the Northumberland Housing Pathway. It's gathered pace more recently, and we are now running a pilot that started in December, which will run through to March. This is around connecting our housing partners and health partners so that we can get seamless and quick support in place if we're recognising issues that are impacting health and well-being around housing. Our staff all go out and they do home environment assessment tools, and that gives us the opportunity to actually understand how a family is living and how that impacts their health. So we're developing that, and hopefully it's going to come out with a project at the end of it where we can build on that for all residents in Northumberland. We've also got an enhanced home environment assessment tool with our partners in the fire service. And again, the fire service we worked very closely with them. They trained our staff around recognising risks to any issues around fire hazards, and we've now got a seamless pathway into the Northumberland Fire Service, who will then go out and do that risk assessment and offer advice around keeping our families safe and healthy in their home. Next slide, please. Another new role that we have is our project support officer, and she is in charge of implementing transformation with our digital platform. So our universal offer that we have for all families in Northumberland, we have our digital app, which is in essence a quick go-to around any issue that will take a family from the journey of conception all the way to 19 or 25 with additional needs, where they will have information at their fingertips. One of the unique part of the app is to be able to direct message into a 0 to 5 practitioner or a 5 to 19 practitioner, and then we have duty staff who cover that during working hours, so that families are getting that quick resolution to resolve any concerns or issues or worries that they have, to allay that anxiety that may develop through not being able to have that face-to-face contact. We've also got our Facebook page, and as of this week we've now got Instagram as well, so we're looking at new ways to be able to reach out to get that universal public health message to families and young people. We have also Feedback Friday, so that's that patient experience. We send out routine surveys after every contact with our families, and then Feedback Friday, we post that information in a You Say We Did format to let people know that we are listening and we are wanting to create a service that is meeting their needs and their requirements. Next slide.
Okay. Jess Towler, she works into the multi-agency early help hub 3 days a week. That role supports the flow of referrals across the system, and she represents the 0 to 19 service. The role is really pivotal, important in providing a timely response for our referrals and ensuring our agreed waiting times are adhered to, but also that the right referrals for young people. Sitting together at the early help hub. Okay. Next slide, thank you. I think further, we've been working really closely and collaboratively along with midwifery and the family hubs to hold a series of locality engagement events, and they've been held in all the 4 localities of Northumberland, looking at what our service offers are, developing that integrated working and how we're going to work together in the future. The events have really provided valuable feedback on what's going well for staff, what needs to improve, what needs we have, and those individual actions that staff can take forward themselves, but what we might need to support them with. We're now in the process with our partners in the family hubs of forming task and finish groups in each area to really develop and continue and take those actions forward. Sort of in summing up, what's going well for us within the service, the transformation that we've talked about, the new roles, our partnership working is going really well with family hubs. Our staff were all part of the work streams and contributing to the delivery of care out there. We've doing a lot of training, some of that multi-agency training, such as Eyes on the Baby, around sudden and unexpected infant death, the newborn observation screenings that you might have read about. So we're continually really to train to ensure that our staff are trained to the highest level to deliver the care. Our recruitment of SCIFIN students and the workforce is also going really well. For the future, we are looking to embed and implement the family plan and to continue building on the partnerships that we're working with and with that close collaboration with the family hubs. Okay, thank you.
Thank you very much for the report. I think there are lots of new initiatives going on here. It's all peppered with quite a lot of triagenous and, integrated pathway and everything. It's good luck. Are there any questions Yes, please, Jill.
Thank you. Not so much questions, more comments. Just say thank you for bringing the report to life with that presentation. It's really clear how much you clearly care about not only the staff but working into and across the community. So and with all the innovative posts that are coming through, it's about that culture shift of working alongside with families rather than doing to families, which is a big culture that we're all trying to work more towards, that enabling approach. So thank you for sharing that. It's also reassuring to see the mandated statistics there, so in relation to what the core requirements are from the team and the Healthy Child programme. So that combination and bringing to life the partnership working with newer partners such as fire and housing is also reassuring to hear from the board, where we're all trying to work much more collectively for that common purpose. So thank you.
All right, Grant.
Thank you. Hilary Snowden's not here today from a primary care point of view, but I visit GP surgeries, and I think one of the things that the feedback I've heard at times is that there's some GP surgeries perceive the 0 to 19 as very positive, and there are some GPs where they've perceived a loss because of the way that the service has changed. And I have met with you, and I thank you for some of the work that we've done that. But I think we've got a shift here about this idea about general practice, I think, used to be perceived as the place where everything to do with health went on in a community. And the health visitors used to be part of that team. And I think this idea about communities and having a prevention agenda and moving health away from GP surgeries is a really important shift of culture. And the work that we're trying to do around Northumberland about, we're calling them at the minute integrated neighbourhood teams, but there's a better way of calling that, I think I heard yesterday, called integrated neighbourhood working. And what I would just say is I would just want to reach out to you and say, with all of this work that we're going to be doing over the coming year to try and I think part of this is about getting GPs to perceive that they need to have a role out with their traditional reactive health role in their surgery, and perhaps move some of what we do with the prevention side of health into family hubs and move the locus. But I think we'll need to have that transformation idea going forwards with this.
No, absolutely. I think echo all your thoughts. It's community asset-based model. I think we are reaching out and working into a lot of GP practices and meeting them and talking about the model where we have the opportunity, and we have done that in quite a lot of cases over Northumberland, and actually it's been really beneficial once we've sat there and talked about some of our innovative roles, the digital platforms. They've been really interested, so I think we need to proactively keep that work going, and we will do so. Yeah.
Yes, Jeff and then Peter. 2 or 3 questions actually. The contract that we have with you, is that an ongoing contract or is it a stated number of years?
John's going to answer.
Question? No answer?
It's a partnership, Jeff, so it's a Section 75, so it's not a commissioner provider, it's working up in partnership.
Right, okay. That's
so it doesn't have an end point in that respect.
Right. Second one is, on page 2, we're talking about the growing health chat. Have we got any figures of the number of users that we have for that? And the second question is related very much to that as well. Is apart from the neurodiversity figures which are in there, there doesn't seem to be any figures at all about the number of residents that we're actually helping. And I have no idea in my head about how many people we're assisting, and it'd be useful to find that out. And the last question is, it's great to talk about community hubs, but not everywhere has them. For example, my area, there is no community hub. So we need to bear that in mind when we're talking about what we're going to do.
Yeah, absolutely.
So 2 or 3 questions.
So the number of health chat we have figures on.
So we have figures on how many people have downloaded the app. bearing in mind it is in its infancy and it's growing, we've got 5,290 as of this morning of people who've downloaded it. So they have the ability to have that health chat. Obviously, it's something that I promote every time we're out, the whole team are promoting it, because it is
QR codes, all
yeah,
those kind of things at every visit.
We wear them round our necks. It's something that we want to grow, because that is the universal offer, and it's about building that resilience in families as well, so that they can potentially learn those skills through our app as to how to find the right information and the correct information, as opposed to, you know, going down that route of finding inaccurate information. So it is growing, but we've got over 5,000 people who've downloaded that.
I think in terms of family hubs, we're very aware that not every town village has a family hub. We are a home visiting service, so all our all the mandated contacts you've seen up there, they are delivered in the home. So wherever you are in Northumberland, whatever rural communities, we will be delivering that service in the home. Within family hubs, there's outreach work. Janelle, you might have...
Yeah, so following on from that Cramlington conversation, a lot of the conversations I was having with families was around a feeling that they didn't have that hub building. Obviously, we're going to hear from around the hub is being more than just a building. It's about the concept of you know, being there to support families. What came off the back of that is we've now got a steering group, and we're looking at outreach options within Cramlington and Seaton Valley, because the voice of the residents was that they felt underserved. So there are opportunities there, and we're working in collaboration, so we'll have wait and stay opportunities so that they can come along, see a health visitor, have that health input, but then also explore what the family hub have on offer as well. So we're developing outreach through that way.
And looking at other venues, libraries, community halls, those kind of buildings that we can utilise in communities that don't have family hubs.
So, Jeff, are you concerned that areas without hubs may be left out? Is that the underlying question?
I'm no expert, I'm sure. Oh, John,
yeah, is that...
I'm no expert, I'm sure you're much better than this. But what I do think is that, for example, Amble doesn't have one. And Amble, people will not travel to Alnwick for their health. They'll go to the GP, which is because that's what they think is where health is. So I don't know how we get over that if we don't have a community hub.
What we're trying to do is to look at that innovation. We're looking at new ways of working. I know that we're linked in with the rural coordinator in the north, who is Glendale, and we've got Millfield, which is an area where there's a lot of families who feel that they couldn't travel to Alnwick for the family hub. So we're going to be working in partnership to look at how do we then take that offer into their community. We're also working with lots of different partners around exploring transport options as well, particularly rurality. How do we make something that's sustainable and accessible for the whole community, not just families?
I think also, you know, in terms of that's around family hub buildings, although we've said we're a home visiting service, we do have what you know as baby clinics, appointment-based clinics in all of these communities. So we do go sometimes into GP surgeries or Amble Health Centre, you know, where we will be delivering weekly or monthly baby clinics, and that is in, you know, some very, you know, we do that in Wooler, we do it in Belford, you know, and across the county, we do have a presence in whatever setting is appropriate for that community in terms of delivering our 0 to 19 service.
Thank you. Peter, please.
Thank you, Chair. Just to make colleagues aware, the Health Watch Northumberland is concluding a piece of work around the health visiting service, as you're well aware. So there will be a report on the findings from that coming to colleagues in due course, and I'm sure we'll be working closely to see how that sort of user feedback is led to service improvement. But I think one of the issues that you've touched on, Jeff, the sort of the drop-in availability of drop-in facilities is emerging in that work. But I think there's a diary date already to discuss.
There is absolutely, yeah, to meet to discuss that, yeah.
Abby, please.
Thanks very much for the report. From a voluntary sector perspective, I just wanted to feedback on that community anchor role that Janelle's been doing. She's very, very integrated within the community sector. She's connected through all the Thriving Together network. She's been at all the Thriving Together events, the Thriving Together Glendale coordinator and stuff like that. So I just wanted to say, from our perspective, I think it's really working that actually that removal of silos, I can't speak to the rest of the work, but that thing that you said at the very beginning about trying to break down those barriers, it has been transformational for that. So I just wanted to give that feedback.
Thank you.
Yes,
Just very briefly, there is an outreach point for the family hub at Amble North and the primary school there. So it's an outreach point, but I can cover that in my presentation, which is another agenda item today. Okay. Chair.
Yes, there is one presentation. Thank you. You've been very thorough. Thank you very much. Yeah. Any other questions? Yeah, please. Yeah.
Thanks, Chair. I just wanted the questions to be out of the way just before I've had some feedback personally from the Fire and Rescue Service, and just to say thanks, because the service that you provided has made a big difference in terms of allowing us to target those most vulnerable and the highest risk within communities. The real life intelligence that you give us really is more valuable to us than the risk profiling that we do alternatively to that. So I just wanted to pass that feedback directly. So thank you very much.
No other questions? Okay, I just have two remarks. I think first of all, it's very pleasing to see collaboration between two stakeholders, fire service and yourself, and then you are doing a few things, going around and checking people's houses for safety and everything. It's marvelous. I really appreciate that. But the second remark is that there are quite a lot of new things you have started, seems to be going well, and I really look forward to you coming back next time with an annual report, how these are all bearing fruits, or whether they require any reform or adjustment or something. So from that aspect, it'll be nice to hear from you. So finally, a question is just, it struck my mind here on page 15, you have been establishing the public health pillar. You are reporting on public health pillar, and then you see, there is a sentence there which says, high volume of inappropriate neurodiversity referrals, and they have been filtered through, or something like that. Can you please elaborate that? I just want to know whether there is a well-being health concern here, or how it is done, what is the origin and everything. Can you please?
I think you may be aware from, I think, the previous time that our 5 to 19 service particularly has gone into 3 pillars. And so we have a public health pillar, a safeguarding pillar, and emotional health and resilience pillar. And I think it's about working with Jess Towler, the project, no, the triage nurse role. It's about getting young people into the right pillar with the right person at the right time, and that reduction in waiting list. We've also developed, you might have read about it, and that's really helped us reduce the waiting list, some charge up kids and some group innovations around seeing young people and children with emotional health and resilience problems. So I think we're just, we started that model in June of this year, so we're continually developing that and hoping, and it is starting to reduce our waiting lists around those referrals, and that the right referrals going to the right place at the right
they
time.
have come to you, they shouldn't have come to you, but they are coming to you. Is that what you mean by inappropriate referrals?
I think it's about the timing, isn't it?
Yeah, and I think the development of the graduated response in Northumberland has been crucial to making sure that there's no delay for families and for young people who are awaiting a diagnosis or going through that process. I think from the information that Healthwatch produced, that was one of the frustrations of parents, where they felt like they were having to go through a ticky box system of until they got to the point that they wanted to get to. The graduated response and the introduction of our pillars and the referral, the triage nurse, has all kind of streamlined that, so that we know that young people are in the right service to meet their needs, whether that is around diagnosis or managing day-to-day issues.
Yeah, signposting them to the right location.
Yeah.
Thank you very much. I think, are there any questions? John, yes, please. Yeah.
Thanks. It was just to pick up on that last point about that cohort of children and young people with neurodiversity. That was actually it was a historical group of children and young people who'd been referred into the service, I think, who actually didn't have needs which could appropriately be met by the service. So the work which has been done, which Rachel's just described about the community triage post and working in early help first contact, has helped to actually make sure that new referrals are directed to the appropriate place, and there's been some separate work which has been done to address those children already on the waiting list who couldn't really be served by that service, to make sure that they were reassessed and directed elsewhere more appropriately. And I think that work is still probably ongoing, isn't it, Rachel?
Thank you, John. Thank you very much. That was yes, Peter, please.
Thanks again. It's not a question, and I'm switching hats here, so forget my Health Watch role. Colleagues may be aware I also have a public appointment that's involved with the provision of services, or the quality of services provided for the armed forces community, both serving and veteran, and those in transition. I'd really welcome a chance for a separate conversation with you about the intelligence that your services might be able to provide about the lived experience of families in those communities.
Yeah. And absolutely, because I think we do go into Albemarle Barracks, and I think there is an ongoing piece of work about to start around that. So, yeah, that would be really helpful.
Thank you.
Thank you very much. Are there any questions? No. So, can I invite Graham to give a short or long presentation on family hubs?
Okay.
Thank you, Chair. Shotgun my way through.
Sorry, Graham. You want to introduce Veronica? Anything? No. Okay. Please go ahead. Sorry, Graham.
Okay. Firstly, I hope that with the presentation I'm going to give just about as an update about family hubs, you'll see the critical and centrality of partnership working linked to Rachel and Janelle's previous presentations. Lots of crossover there, and absolutely is front and centre of what we do and how we're approaching the family hub work. Also give apologies for those of you at the System Transformation Board. This is the same presentation, but slightly tweaked, but it's there. And again, just taking the point, it's not in the presentation, again, the importance of the early help triage, which we've just talked about here. I think the critical nature of trying to identify that early support on a partnership basis to get the right support at the right time, the earliest stage, I think is a real strength here, coordinated through our front door and our early help triage system. So just to confirm those points. So what I'm going to do is just a very quick overview of where we're at with the Family Hub developments, give you just a brief outline of the history and what we're doing, and then happy to take any questions at the end of that. So can the next slide, please. So again, just taking on Councillor's points there, just about where the actual buildings are in terms of the family hubs are listed there, but also outreach points, again, a couple of outreach points in the military as well there. But again, the point, whilst co-location is desirable, particularly given the rurality and the nature of Northumberland, it's about the collaboration, the partnership working that's critical, as well as where the actual buildings are. But that's just a list of where the actual buildings and outreach points are across the system. So, just in terms of an overview of family hubs, broadly started them in March 22, but a soft launch in September 22. And I've got to say, there's made significant progress. I've not a lot of time here in terms of where we have got to in partnership with communities, with all the agencies to where we've reached. Northumberland is one of 75 local authorities to implement this family hub model, and we're only one of 14 local authorities who were awarded Trailblazer status, which has given us some additional funding to go further and faster, particularly focusing on the 0 to 2 age range and support around those. So the part of overall integrated family services, and the difference is we're now talking about 0 to 19. So if we go back to previous children's centre models were 0 to 5, family hubs are set up to do family hub early intervention, prevention work on a 0 to 19 basis, albeit I have to say it, the majority of the national funding coming our way is focused on the 0 to 5 age range. But again, just some of the key points about it is about integration of services, working alongside voluntary and community sectors and sharing and making sure that people can access the support at the earliest stage, And again, the key partners, you've heard it from the previous presentations, the critical centrality of our partnership working with our 0 to 19 service, with our midwifery services, primary mental health, and a range of other services as well are already well located in there, including fire and rescue services as well. So again, I think a very good model of partnership working. So a general update, when we're moving from what were children's centres to early help, we did have significant commissioning arrangements with Action for Children and Barnardo's, which we ended, and that was ended on a positive note, but it's just because we wanted increased flexibility in terms of be able to move quickly with the developments that we are outlining that you will see today. And that's worked well, but it has led to, there's been a major restructure, which I don't want to play down how challenging that can be for staff to go through a whole restructure across the whole service to make sure we've had consistent jobs, posts and approaches across early help and prevention within the council to make sure that worked properly. But again picked up with the System Transformation Board, actually the key principles here are access, that people know where to go and can get to the services easily and can get signposted early. The critical and fundamental nature of relationships being core of our work, whether it's us as partners and how we work together, but more crucially, how we effectively engage with the children, young people and families, particularly with those who will find it harder to access and get to our services, and making all those connections work for the benefit of our children, young people and our families. Colleagues, health colleagues before have already talked about the integration events. I think they were crucial in terms of bringing people together, sharing knowledge, understanding and the developments there. The funding basis is on a current 3-year basis, say primarily focused on 0 to 2, but we are, and again I do think we're ahead of the game nationally in terms of how we're trying to look to develop our services in the 0 to 19 age range. Critical and central to that is obviously the family's involvement. We've got parent carer panels, which I'll come up to. They've started to set up. They do need some more work and develop to make sure they're absolutely front and centre of how we do that. But there have been a range of consultation and development events to inform where we go with this work. So I'm just going to give a quick overview of some of the services we've got. We've got the prevention and intervention pathway. This is a range primarily of group work opportunities in terms of whether it's learning together through play for parents with young children, whether it's about the Henry programme, which helps healthy childhood and upbringing in there. So a range of different offers that helps support parents in the care of their children. And the programmes themselves have been developed in the presenting needs of our population. So we've evolved and developed the range of offer of this prevention and intervention pathways, and where we have and where it's possible to do, we've evolved and developed that in consultation with parents with examples there. And I've got to say the feedback, I mean, we do a range of ways of understanding the quality of what we do, including visits from myself and colleagues where we land on the service with looking and getting feedback from parents. And inevitably and very consistently, the feedback from the parents about the groups we run, how well they're engaged with those, how well they benefit from. But equally, the fact that once they're engaged with one group, they then find out about the range of other services that can be accessed through the Family Hub to get to what they need at whatever point they need it. In terms of the group work, though, we equally, and I'll come on to it, we do obviously offer some individual family or children's interventions, but where it's helpful to do so, we can use the content of these groups on an individual basis as well, where that's right for that family or that parent, some of whom may struggle to come into the group settings for a range of reasons. So we try and use that flexibly. And we've also developed, I think, learning from the pandemic about how we can virtually offer groups. Now, ideally, we would want face-to-face. We've got the vast majority of them are face-to-face. But there are certain groups that have been run virtually that have been really effective because it's offered a greater flexibility. And the example I will use is about how effectively they've been used to engage fathers. Now, that's a key push for us to make sure we're engaging with fathers at the earliest possible opportunity through our midwives at the point of pregnancy for a range of reasons. But actually engaging dads through the group work virtually, which we could offer at different times of the day and evening. We've been able to then run it for dads across the whole of the county, so not limited geographically with some of the challenges of getting people in. That has worked really well and effectively. So we've maintained that learning from the pandemic and using that methodology where it's right to do so to engage people. Just a little bit about family help. These were our work called early help workers. So they would offer targeted interventions at a higher level of need. So beyond universal, where we think children, young people and families need some more targeted individual, I don't like the word casework, individual work with families to support and help them in a range of ways. And again, we use approaches, they undertake assessments. A whole family approach is crucial for us, not just the solely engaging with the fathers, but critically across all of social care work. Front and centre is making sure we try and engage with the wider family network to make sure they're engaged with and maximising the support and help they can offer to the parents and carers of the child. And that's a critical and front and centre for us. And there's a range of processes in there where we work together as a team around the family meetings. That would be with the family, or the staff who are involved and working with the family would meet regularly to share the progress that they're doing, make changes and amendments, and making sure that if we have to change the services, or even if we've achieved through the family help service what they need to, we will close that, but make sure that the ongoing support is offered through that. And again, these family help workers will deliver the intervention programmes that I mentioned in the previous slide. So we continue to develop the offer there. So just talking a bit about, again, covering what colleagues talked about, the digital offer and maximising how we can reach both digitally and virtually. I've covered off about some of the virtual offer through the GROAT work, but a range of ways in which we can offer support to children and people and their families digitally are listed there, but equally being acutely aware that not everybody can access, has the technology or the abilities to do that. Absolutely got to recognise the limitations of digital poverty and how we can mitigate and support families in those circumstances. So again, let's say health colleagues have covered off already the stuff about the post of the QR code and the ways in which we do that. And again, I've already talked about the virtual group deliveries that we've offered. So again, just for this, really particularly concentrating on the partnership working with health, and again, it'll just be duplicating, but I think reinforcing some of the points that colleagues have made there. About the Family Help, we now call it the Family Help Partnership Board. It was an implementation board. I think we're now implemented and we're now moving forward with that. So that's now a partnership board. We've got the governance of that will come to the Children and People Strategic Partnership and then up into this board as well. So again, the chairing is there by multiple health colleagues involved in those developments. Co-location as well, wherever we possibly can with health colleagues, absolutely works very well. I'll come to it later on, but Dame Andrea Ledson visited our hubs last year and was really impressed by the fact that as parents were coming in, the mother was pregnant, we were engaging with the father at the earliest possible opportunity to make sure they were aware about, connected to the family hub and the range of services that were offered. So again, that partnership working again with the services is front and centre of what we do. And again, those are some of the bottom point, just some of the range of supports and groups that we offer and the services there through our health colleagues. Okay, again, just integration help, just looking about the range of services. We've done a lot of work as we've developed the hubs, mapping the range of services in each of those localities. And one of the things that we've done as we're trying to develop the offer for young people and teenagers particularly, is actually what we've mapped the range of services that there are. And there are a lot of them. But one of the things we want to do is make sure that there's that connectivity that I don't think was there prior to the family hubs. We've developed specific posts that we're calling young people support workers, which will help make the links so that we can see a young person if they need certain things, that we've got that information where might be the best place to access the support that I might need, and trying to move away from groups working in isolation. So that is one of the key elements that we've continued to develop. A range of other services and processes there around working with colleagues in with colleagues in health, which have been touched on before. And again, picking up the point that Graham talked about, interesting, we talked to the System Transformation Board about the points that we're making here, actually some very positive links with a number of GP practices, more of a challenge in developing those productive relationships with others, but equally coming out of that meeting, one of the colleagues from the Wooler, one of the Wooler surgeries made the point about very happy to be contacted. I've been in touch with our family hub locality manager in the north and we'll push that forward. So I think the points that Graham absolutely was making, I think it's incumbent on all of us to make sure we make those partnership working as effective and at as an early stage as possible to maximise what we get for our children and people families at the earliest point. Again, other works, again, as well described about the community development and social prescribing, front and centre of what we do, really important in terms of links with our communities there. And again, very positive work with some of our GP practices, more to do. And again, wanting to be front and centre as we develop the integrated neighbourhood working. I think the links with family hubs will be critical about how effectively we can make those things work. Again, just more digital work about how we've promoted that through a range of ways, but particularly through the information that's available digitally and otherwise. Eyes on the Baby project, we've already talked about again. We didn't practice this before, to be honest. We've just, it just shows that we work together without playing before. But I think the Eyes on the Baby project, again, I think is really important. Just on a slightly separate note, we have seen an increase through our safeguarding partnership about unexplained deaths of children younger in the younger age range. We had a task and finish group developing through that, and I think this group and project as well is one critical element which will help mitigate and look to support work going forward in terms of support for parents with young people, with young babies. A lot of information on there, but that's just about developing our family panels to make sure the parents, carers are actively involved in the most effective way. This is work that needs further development, but we have got a very strong basis of having set up family panels in all of our family hubs in our localities. It needs further development to make sure they're absolutely core, front and centre throughout whatever we do. And finally, just we have external views of where we're at developmentally. So last August, we were chosen, we did offer, to be fair, to be part of a thematic review undertaken by CQC and Ofsted. 6 local authorities were chosen nationally to form part of a thematic review about the family hub development to support regulation going forward, and also just to develop learning about how family hubs could develop and support the national developments. And actually the findings and feedback, it was given verbally. We didn't get a written report from the colleagues, but we made sure we made note of everything that they fed back to us. And those were some of the key points there, particularly the staff. That was front and centre of the feedback. Passionate, child and family centred, skilled, flexible to meet need, positive and reflective. Those were actual quotes from our inspector colleagues. Very positive about our partnership working, building from a strong base. Note the work with midwifery about the earliest engagement possible, ports of birth registration to capture that, and also good examples of joint working, for example, DWP being in our family hubs, parents being able to access that where supporting. Was it inclusive in a range of ways? I mean, my background is social work and social care. A lot of the services that I will be responsible for will have a stigma and can have a stigma attached to them. I think one of the strengths of the family hub offer, picked up by the inspectors, that it is a universal offer which can lead to support to other services. I think there's much more work at the very heavy end of social work intervention to link those more effectively. But I think they saw that as a very good start, with parents willing to and wanting to access family hubs, not thinking it's a stigmatising just for certain groups of people, which I think was a really positive feedback that we got from the inspectors. They thought our partnership and leadership was very effective, that we did know ourselves well, we knew where we'd got to, but equally where we needed to further develop, which chimed with the things that they found. But throughout that, again, the inspectors talked to lots of parents, and uniformly the positive feedback from families was really lovely, actually, and lovely from our staff to hear across the partnership. And again, I've already mentioned that Dame Andrea Ledsom came earlier last year, and again was very positive about what she found about our offer here in Northumberland, and we'll take that back nationally. So that's a very quick run through where we're at and the strengths, I think, of where we're at, but I'm very happy to take any questions.
I think it's a very good information-packed presentation and full of positive and upbeat nature. Are there questions? Yes, please, Graham.
Thanks, Graham. I don't think you should apologise for doing it at STB in here, because I think this is a different audience and also a slightly different theme. In my mind, I'm mapping what we're doing here to what's in our health and wellbeing strategy. And what are the metrics in our health and wellbeing strategy that would tell us about success of this? I'm thinking about the inequalities plan as well, and I'm wondering if we're now at a time where, if we knew what the school readiness rates were by family hub, or the neighbourhood that they serve, or tooth decay, some of these are, and if all of the people that are working into these communities, and actually the community themselves, know what the priority is in that area, is it time to start thinking, how do we make a difference on these things that we're actually measuring by using these tools that we're developing? And actually the agencies all know what's most important. And you start to create a specific action plan rather than a generous offer of all the things that we have available. Because I think what you said was, what's happening is that what is giving is based on what the perceived needs of the people that are presenting is. And that might be different from what the population's need is in terms of inequalities and well-being in the long run.
I think that's a very helpful development. I think to help focus, absolutely, there will be different needs in different areas, and being able to bring together our partnership performance information, but also our qualitative information. What do we know about our localities that might help us if and where we do need to target to need more specifically? I think that's a very helpful suggestion, and I think that's something we need to take forward as we think about taking this forward.
If I could just build on that, and I think it's really relevant to mention the Cramlington conversation that was referenced in the first presentation, and it's about one of the principles in the inequalities plan is residents' voice equal to data. So it's a great point well made, Graham, around how we are able to track the inequalities. So school readiness, yes, we'll have a Northumberland level, but what is below the Northumberland level? It's really important for us to be able to look at the difference, but that place-based conversation is the nuance, isn't it? And that's where we can tweak and make the offer more bespoke based on what that demand looks like. That links with the voluntary sector, and where else can people go to for advice and guidance beyond the public sector offer.
You want a question, Emma? Oh, no. No, sorry. Oh, sorry. Alistair, please. No, you put the hand like this, so I thought you want to say. Yeah, Alistair.
Model, it's very supportive. I suppose one of my questions is, if we've got family hubs and we're looking at areas without family hubs, how do we also map out the public sector estate related to health and social care? Because we've got mental health teams in areas, we've got primary care, we've got health hubs. Are they utilised, 8 till 10, 7 days a week, or is it bits? And how do we make sure that other bits are not looking to expand because they're short of space when the family hub down this road has got space, or vice versa, and there are lots of sectors, and I'm just conscious that everybody then builds their own need, and actually collectively we end up paying for that because estate costs, and actually there may well be bits where we can look at estate rationalisation, which then means that the money goes back to services rather than buildings, which is what fundamentally we need. So it was just, how do we map that out? So that's not about the service model, it's about the space model.
Yeah, and yes. And I think equally that's then about the quality of the relationships within the localities to be able to have those conversations to maximise whatever the estate is. And I'll be acutely aware of some areas where we would want more space. And hopefully in one of the areas we've actually managed to find that through the relationships we've got. But I think that does need to be done systematically. Absolutely.
Abby, please.
I think just to add to that, I would just, when you're looking at space and estates, it's reflecting proper community assets as well. So the wider ask about schools and things like that, how can we use all of those spaces that exist rather than continually reinventing them?
Thank you. Yes, please, Wendy.
Graham, I just wondered, and apologies if I missed it, what does Henry antenatal mean?
Well, I was checking that before, and I'm going to fail on it because healthy, and I couldn't remember. And I knew somebody would ask that, and I forgot. But it is about healthy upbringing, but also the emotional well-being of children is what it is. And one of my health colleagues will shout at me afterwards for not remembering what the acronym stands for.
Sorry.
No, any acronym beyond 4 words is confused. It's difficult to remember. Any other questions? Yes, Peter, please.
Not so much a question as to loop back to what you were saying, Graham, and just reflect on the discussion we just had about place and space and sort of physical assets, and kind of connect that in my head with the inequalities strategy focus on not just communities of place, but also of interest and experience, and how we overlay that. I think it's a really interesting question that I know we're working on, but I haven't got the answer. But I think it's really encouraging that we're all thinking that way.
Thank you. Yes, please.
I'm kind of looking at Lynn in the audience a little bit, but this is probably a time to say our STB following discussion around some of these topics last time, we did agree that we were going to have a task group which was of all agencies involved to think about community integrated working. We have a model of dots on a map, which is the first time we've seen one, but there's a similar model which is dots on a map for PCN groupings, which is different. And there's a piece of work to be done over the coming months which starts to form up actually what should it look like for Northumberland and how do we overlay the data that Jill was talking about. And there's a health agenda about integrated neighbourhood teams, and there is some funding coming through that has some markers about success, but it very much has to fit alongside the health and wellbeing strategy and everything else. So it is a piece of work that needs to be done this year, I think. Yeah. Lynn?
So just yesterday we had the Northumberland GP Collaborative, and we talked a lot about what do we even mean by integrated neighbourhood working is what we came to the conclusion. It's not about teams necessarily, it's not about bums on seats, it's about making sure that we're all working collaboratively. And I think, you know, the family hubs is an excellent example, so we didn't want to start something afresh. I think, as Alistair said, it's about looking at the estates that are already in place. How can we really resource things? And from the conclusion yesterday, the Task and Finish group is going to help enable a kind of framework for that integrated neighbourhood working. And I think for me that it has to start with what's already in place around family hubs. So thanks very much for setting the foundations, I guess, and making our job a little bit easier.
Thank you. Any other question? I have a very vague question, so I'll spit it out. You know, I looked at the thematic review. It's excellent. I mean, and I also understand this idea of hub-based service provision in terms of in collaboration with health practice and other things. It's a nationwide effort, yeah, because there are 6 councils that have been evaluated. So what I'm asking is that, I mean, I have a feeling, please correct me, that the scope of our aim, or the breadth of the scope of our aims, like, for example, we have these family hubs, and then we also combine, you know, tackling health and inequality, getting local intelligence and other things. Are we kind of a unique council in combining lots of things over this model and are trying to achieve? Or are there some fellow, if so, hats off to you. Otherwise, are there some fellow travelers, other councils, so that we can compare notes as how they are doing? You know, that's the kind of, it may be a vague question. In that case, you can tell me. I'll email you, Paul, or something. Yeah.
No, I think that's a reasonable question. I think it is a national development.
Yes.
We would have links, for example, regionally. I mean, there are regional meetings with all our family health managers so that we can learn and share from each other regionally. But as authorities, partnerships will be in different places. And equally, I do think how we develop here in Northumberland will be very different to how they may want to do it in Newcastle, for example. And I think it is about being very specific, developing it for whatever your locality and partnership area needs is crucial. So it's a bit of both. There is learning that's coming. I've got to say, coming out of those 6 that they've looked at nationally, there was supposed to be a national report in November, and I've still not seen it. So we haven't seen what the collation of that is or what the future development of that is. But again, we have also got links, or I'll have links with the DFE as well about things as well. So we can pick up national developments as well.
Right. Thank you very much. Thank you. Are there any questions? No? In that case, I think we are coming. Yes, there is no urgent business. Oh, health and well-being forward plan. Okay. So, if you have any comments, yes, please, Wendy.
I wondered if maybe we could have safe havens on the next agenda, because I understand my colleague from CNTW might be able to enlarge on it. But the first safe haven for Northumberland should be opening either the end of this month or the beginning of next month. And I just think it would be nice just to publicise and talk about it.
Thank you, Wendy. I will ask Jill.
Yeah, just to say that on March, we're actually going to be reducing the number on a regular basis to no more than 3 agenda items per board, because it does take quite a lot of time to get through to have meaningful discussion as well. So we're going to be taking off the refreshed joint health and wellbeing strategy, putting that to April. So Wendy, if it's okay, and pending yourself, April or May would be an opportunity to talk about safe havens.
Yeah, that's a good contribution. Thank you, Wendy. Is there any other comment on future plans? Okay, none. Okay. There is no urgent business, and I think a date of next meeting is on 14th March, as Jill alluded to. And this brings to the end of the meeting at 11:10. Thank you very much for coming. Thank you very much for all your comments and questions and presentation as well. Thank you.